Dr. Denise, the CEO of Pancreatic Cancer Foundation. I would like to welcome you to our Pancreatic Cancer Foundation page. Our goal is to create an awareness of the challenges, support and guidance experienced in managing cancer care for sufferers, family, carers and friends. To engage with us, don't forget to subscribe to our channel. Click our notification bell. My name is Dr. Denise, the CEO of Pancreatic Cancer Foundation. I'd like to welcome you to today's discussions on pancreatic cancer. Our host is having our speaker is having a lot of issues with the network. So we're going to try and see how far we get. And if we realize it's not going to be as productive as we hope, we may have to reschedule it. But let us give it a shot and see how far we get. If it doesn't work, we'll try and reschedule it for some other time. So good morning, everyone. Today we're talking about pancreatic cancer. And in the house, we've got Dr. Tessy. Dr. Tessy, can you please confirm that you can hear us now? Dr. Tessy? Dr. Tessy?
Yeah, am I audible?
Okay, I can hear you now. Yes, we can hear you now. So let me continue. Dr. Tessy is a clinical oncologist and a nuclear physician with over 13 years experience providing clinical, technical and strategic contributions for the prevention, care and treatment of cancer. She is a fellow of the West African College of Surgeons and the College of Medicine, South Africa. Currently, Dr. Tessy heads the oncology unit and is the chairperson of the Multidisciplinary Cancer Committee of the Federal Medical Center, Abuja. Dr. Tessy, you are welcome today to today's discussion on pancreatic cancer. I am mindful of the fact that the fluctuations in the network, so let's see how far we go. If we do not feel happy with it, we can reschedule it for maybe next weekend to be able to make sure the message is gotten across on pancreatic cancer. I hope that is okay with you.
Yes, it's okay with me. Thank you so much for having me. Can you hear me?
Yes, I can hear you now. We're good.
Okay, I would have to be asking if you can hear me because of the network fluctuation. Good afternoon, everybody. It's a pleasure to discuss pancreatic cancer. November is Pancreatic Cancer Awareness Month. And I'll just take you through a short, I won't call it lecture presentation on what the pancreas is and what pancreatic cancer is. Can you still hear me?
Yes, we can.
Okay, so the pancreas is an organ that is located in the abdomen. I'll try as much as possible to use simple terms. Very essential in the conversion of food into fuel that is needed for the body cells to function properly. So the pancreas is a very, very vital organ to the body. And it has two main functions. It has an exocrine function where it functions to produce enzymes. That enzymes are chemicals that the body needs to digest food substances that is eating. It also has an endocrine function where it helps to produce insulin. Insulin helps to lower blood sugar, and it also produces glucagon, which helps in the raise blood sugar. So it helps in maintaining a proper blood sugar balance. So with these two functions, main functions of the pancreas, we can see that the pancreas is a very, very vital organ. And it is also very, very strategically located. Strategically located, I mean, it is surrounded by very vital organs that when it is affected, it by extension affects these organs also. The pancreas practically has a head, a neck, a body, and a tail. And I'll just quickly go to the main matter of the day, that's pancreatic cancer. It is the third leading cause of death from cancer in men and women in the US. Only lung and colorectal cancer cause more deaths. And it is said that pancreas cancer may likely even overtake colorectal cancer as the second cause of death in a couple of years. So what it means is that the incidence of pancreatic cancer is increasing. In the US, you have approximately 47,000 people diagnosed yearly in the US for pancreatic cancer. And it is also projected that, you know, in the year, by 2030, it might be the second commonest cause of cancer death, second to lung cancer. It is very, very common. It is more commoner in men compared to women with a ratio of about 2 to 1. And it is almost twice as common in Black male than the white men in US. The incidence is very, 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 very age dependent. And we find more than 80% of the cancer occurring between the age of 60 and 80. Can you still hear me?
Yeah, yes.
Okay. So I just want to ask, people keep asking, is pancreatic cancer a death sentence? Well, I wouldn't say yes, and I wouldn't say no, because it is one of the deadliest forms of cancer. Early detection is also very uncommon. It spreads very rapidly. It has high incidence of related mutations, and it reoccurs very frequently, even when it is treated. And the mean survival of a patient that is diagnosed with pancreatic cancer has been studied to be between 12 to 18 months. So I want everyone to ask whether it is, to conclude whether it is deadly or not. But the risk factors that are associated with pancreatic cancers are the things that we will need to know. Most of the cause of pancreatic cancer remains unknown. The lifetime risk of developing pancreatic cancer is between 1 to 3%. And that means the occurrence is low. There are so many conclusive links and risk factors. There are various modifiable and non-modifiable risk factors. For the modifiable risk factors, we have things like tobacco smoking, alcohol ingestion. This has been seen to be implicated in the cause of pancreatic cancer. It is seen in most of the high-risk group of patients with pancreatic cancer. Things like age, we can see that most of the pancreatic cancer you see occur in elderly people between the ages of 60 and above. The male gender is also a factor that you cannot modify. It is more commoner in males. People with chronic pancreatic diseases like chronic pancreatitis and pancreatic cyst are also at high risk of developing pancreatic cancer. We also have association with dietary factors. There is positive association with red meat consumption, high carbohydrate intake, and there is a protective effect of dietary fiber and consumption of fruits and vegetables. There's also a positive link between coffee consumption and the development of pancreatic cancer, although this is not conclusively proven. Obesity has also been associated with the high-risk group of patients who develop pancreatic cancer. Also is then long-standing diabetes. There are also chemical agents like benzene and nitrosamines that have been implicated as risk factors for pancreatic cancer. The removal of gallbladder and certain surgeries that occur around the area of the pancreas, the gallbladder is actually very closely related to the pancreas, can also lead to, can increase the risk of pancreatic cancer. We also have genetic factors. almost about 10% of pancreatic cancers are hereditary in origin. And you have about 8% of that, those percentage being familial. That's when you have first or second degree relatives that have pancreatic cancer. So there's no apparent familial trend for the tumor, but there's increased risk that has been seen in patients that have relations with pancreatic cancer. There are also related gene syndromes, some syndromes that when you have them, you have pancreatic cancer associated with them. I don't want to bore us with big names, but we have to bear it in mind that these are things that increase the risk factors for pancreatic cancer. So what are the symptoms and the signs that we see when a patient has pancreatic cancer? It is really, really very hard to diagnose because the presentation varies. The presentation is largely unspecific, and that is why you find patients presenting at the late stage when it's only obvious that it has spread to so many places.
We can't hear you anymore. Dr. Tessy, you stopped now. You stopped.
Commonly, other symptoms like found in like 50 to 90% of patients without pain. Please, can you still hear me?
Yeah, you went off at a point. You went off when you were telling us about when you were trying to start the introduction to the symptoms.
Okay, so the symptoms, you can hear me now?
Yes.
I said the symptoms are in most cases, very commonly, the patients may not present with any symptom. But when they present with symptoms, we have things like abdominal pain. We also have abdominal swelling or a mass in the stomach. Let me use that word, in the abdominal area. There's also yellowness of the eyes, unexplained weight loss. Can you hear me?
Yes.
Okay, unexplained weight loss, poor appetite, fatigue and feeling of tiredness, unwell, abdominal bloating, indigestion. We have nausea and vomiting. There might be change in the stool frequency or the color or the consistency. Usually the patient might have pale or oily stools. There's also itching, generalized body itching. Unfortunately, most of these symptoms are seen in the late stage when the patient is already at the late stage. There's also new onset when a patient presents with new onset of diabetes or diabetes that has suddenly become difficult to treat. Can you hear me?
Yes.
Okay. And in the late stage, when it has spread to other organs, you start finding symptoms that are not even related to the pancreas, like cough. When it has spread to the lungs, you have cough, difficulty with breathing, back pain, bone pain when it has gone to the bones. And even patients can even present with altered consciousness when it has spread to the brain. Abdominal bloating, indigestion are all part of the signs and symptoms. Can you still hear me?
Yes.
Okay. So what is the natural history of this cancer? The truth is that no cancer occurs just like that. It must have been ongoing for a long period, but it's undiagnosed. Can you still hear me?
Yes, we can.
Okay, sorry, I have to be asking so that I don't just keep talking without you people hearing.
No, it's fine.
And okay, so it takes between 15 to 20 years. The patients, of course, have, it starts that way. But the problem is that it is salient and no one knows until when it's in the late stage where the symptoms are obvious and it's affecting the pancreas and all the surrounding structures. The stage at presentation is abysmal. I would say that, because more than 50% of pancreatic cancer patients are seen at the late stage. Late stage, I mean at stage 4. We have more than 80% of patients presenting at advanced stage, that's stage 3, stage 4. Only about 20% of patients who present as early cases. So we can see that the presentation is abysmal. And as you go from early stage to metastatic stage to where it's stage 4, the survival decreases. Patients with early stage disease have like 40% 5-year survival rates. But for patients with stage 4, you have almost 0% 5-year survival rate. So what this is telling us that is that it is obvious that we need to get this disease at an early stage where the patient can access optimal care and have high chance of survival. Can you still hear me?
Yes, we can.
Okay. So it is very important that patients are gotten in the early stage where the chances of survival is high. So early detection is very, very important. And what does the early detection entail? The disease most often presents late. So what do we do? What do we concentrate on? We must have very high index of suspicion. We must also look for subtle early signs, and we need to know where, whom, and what to look for when we see patients. Because the disease is not too common, 1 to 3%. That means it's difficult to get patients in high proportion to carry out studies to be able to get the risk factors, to get trials and all that, to be able to conclude on how these patients can be screened. So we need to identify patients that are in the high risk group, and then change over time the pattern of presentation. And so what do we look out for? We look out for the demographics of these patients. We concentrate more on patients the aged patients. That's patient, of course, we said that the risk increases with age. We concentrate on the gender and even the race. It is said that it is more aggressive and even more commoner in the Black Americans than the white Americans. And we also look at exposure in people that are exposed to long-term use of cigarette smoking, and of cigarettes and then alcohol. We also need to look at people that are obese, people with low physical activities, and those with chronic diseases like chronic pancreatitis and pancreatic polyps, and then we can follow them up. Very importantly, we also need to look at patients who, pancreatic cancer patients who have died. We need to look closely at their relatives to pick up the chances of them having pancreatic cancer at an early stage. And then some comorbidities like diabetes. We need to look out for diabetic patients, those that are diagnosed, sudden onset diabetes that are diagnosed, or patients that have been diabetic but suddenly their diabetes become uncontrolled. Those are people that we need to look closely at. So in essence, early detection will need a very high index of suspicion, and it will need us to really work on it. Can you still hear me?
Yes, we can.
Okay. So for the screening of pancreatic cancer, there are a lot of challenges to the development of screening processes. A screening process should be safe, it should be fast, cheap, and easy to perform. But of course, I told you that the high risk group of patients with pancreatic cancer is low. You get like 1 case in 100 people for ideal high risk group that would qualify for screening. But in pancreatic cancer, you get about 13 people in 100,000 people screened. So it's not it's not very significant. And then there's also low rate of sporadic occurrence, like 1 to 3%. So getting a screening process for diseases like this is more difficult than when you talk of like breast cancer, you talk of cervical cancer, where you have established screening processes. There is no one screening test that is effective, safe, and can be rolled out for pancreatic cancer. Can you still hear me?
Yes, we can.
Okay, so it is very important to identify high-risk group patients and follow them up in high-risk clinics for active follow-up in clinics, so that they can be followed up yearly, and when the sign of changes, then treatment can be enacted. So who are this high-risk group of patients? Patients with new onset diabetes, or patients who have sudden poor response to their diabetes treatment. They are high-risk groups and they need to be identified and followed up. You also have patients with chronic pancreatic diseases like chronic pancreatitis and polyps. And then you have patients who have first-degree or second-degree relations that have had pancreatic cancer in the past. So you identify this group of patients and then you follow them up. Okay. There are also biomarkers that are measurable in the blood, the urine, and tissue that can be used to help to screen patients. But all these are still not how will I put it now? They are still not well outlined like you have in breast cancer, where you say, okay, screen, do mammography yearly, do a self-breast examination, do monthly self-breast examination and all that. They are not yet well outlined, but there are common markers. They can also do DNA assay, and then researches are really ongoing to see that a well-outlined guideline for screening of pancreatic cancer is available. How do you diagnose this? There has to be very high index of suspicion. And then when patients present with symptoms that are suggestive, then you can do ultrasound, CT scan, MRI. They can blood can be taken for blood sugar, liver function tests, because most times when the pancreas is involved, by extension, the surrounding organs that are associated in its function, like the liver, the gallbladder, are also affected. Then in most cases, when there's high index of suspicion, then a biopsy will have to be taken. But unfortunately, the liver is such that it is located in a place, I could not share my slide. I will have shown you its relationship with the liver, the gallbladder, and so it is very difficult to take biopsy. But then endoscopic biopsy can be taken, and then genetics testing is also very important in the diagnosis. The treatment options, there has been significant improvement in the treatment of pancreatic cancer over the years, even though we still have very high death rates from pancreatic cancer. The main aim of the treatment is to extend and prolong the life expectancy of the patient. Even when patients are diagnosed at stage 4, there is a lot of things that you can still do to make the quality of life of this patient very good quality of life, and make all the symptoms that the patients present with bearable. The most important treatment option is surgery. Unfortunately, more than 90% of patients that will present with pancreatic cancer are not candidates for surgery. Why? Because most of the pancreatic cancer that are amenable to surgery have to be early tumors that have no evidence of spread. And then the patient has to be in good general condition. But most of the time when you see patients with pancreatic cancer, there's already evidence of spread, and they are usually weak and not in good general condition for them to be able to have surgery. Then chemotherapy is another means. More than 50% of patients will require chemotherapy. This is because their disease is already advanced and they might not be amenable to surgery. There's also radiotherapy. Radiotherapy can be added after surgery, or it can also be used as a palliative measure to reduce pain, because the patients are usually in very severe pain. And then there's also immunotherapy, which targets the signal pathways and mutations. There are a lot of mutations that are associated with pancreatic cancer. And so there are a lot of studies going on, and a lot of immune therapy are being churned out daily to make sure that patients can access that. Then most importantly is the palliative support, the palliative and supportive care. This is very important in patients with pancreatic cancer because a lot of them present when you can do little or nothing. But then, as I said, it is important to improve their quality of life, to help them to bear the symptoms that they present with, especially pain, and support them as much as possible. What would I say as a summary? I would say that pancreatic cancer has a very poor prognosis. We need to pay attention to all the factors that are highly implicated. We need to pay attention to our diets, avoid diets that are high in saturated fats. Can you still hear me?
Yes, we can.
Okay, so we need to pay attention to our diets, avoid diets that are high in saturated fat, red meat, processed meat. We should have more of food that are rich in vitamins, proteins, low calories, and high fiber diets. Have food that are rich in fruits and vegetables. We also need to pay attention to our weight, make sure we maintain the ideal body mass index, maintain healthy weight, have enough physical activity, at least 30 minutes per day, and a total of at least 150 minutes of physical activity in a week. We have to pay attention to alcohol ingestion and smoking. It should be to the barest minimum or none at all. Then we need to pay attention to the high risk group patients that are high risk, that are classified as high risk. I have already mentioned them, those with relations, those that are diabetic, those that have chronic pancreatic diseases that are not cancers. They might, after a long period, progress to become cancer. So we need to pay attention to high risk group. And lastly, we need to be very conscious of our health and have a high index of suspicion, because the disease has no specific symptoms. Most of the symptoms are non-specific symptoms that you can get in other diseases. So it makes it very difficult to get it in early stage. I think I'll stop here. Thank you for listening. I'm sorry I couldn't share my slides. I had some beautiful pictures, but I couldn't share the slides to let you see them.
Thank you, Dr. Tessy. Actually, it was very detailed, and you've thrown up quite a lot of question marks. And as you would appreciate, because I already come from the experience of living with cancer, it has brought about some questions. But from the general public, there is a question that has come up, and I'm going to ask. I'm sure you said it, but I'm not very clear. Now, you said something, so I'm going to say what it is. It's something to do with the staging of pancreatic cancer. If I'm right, I understand you. Okay, so can you go back to that? Let me just, maybe that will help.
Okay, so the staging of pancreatic cancer, I said more than 80% of patients who present in advanced stage. The advanced stage of cancer is actually the stage 3 and 4, where your aim of treatment as at that time, because of the spread to local surrounding tissue and even distant spread, is not cure. And so unfortunately, in pancreatic cancer, about 80% of the patients who present at advanced stage. Out of these 80% of patients, 50% of them or more present with the stage 4. Stage 4 is worse. It has spread to distant organs like the lungs, the liver, the brain, the bones, and the patient is not susceptible to cure. Unlike in the early stage, can you hear me?
Yes, I can hear you.
Okay, so unlike in the early stage, the stage 1 and 2 patients but there we have like less than 40% of patients and 20% of patients presenting at this stage, where surgery is the main modality of treatment. And when patients are gotten at this stage, the aim is actually to cure the patient, remove the pancreas, which is the source of the cancer, and make sure the patient is cured. But unfortunately, you get less than 20% of pancreatic cancer patients presenting at this stage.
Thank you for that. Thank you. Oh, okay. Okay. So I've got a question here for you. What tests can be used at early stage? That's 1 and 2. Because Dr. Tessy, you've mentioned liver and blood tests. I do know about blood tests. That's the markers test, isn't it? Cancer markers.
Yes.
Okay.
Okay.
That's the question. So help us here, please.
Okay. So as I said earlier, there is no outlined screening process for pancreatic CA for now. And that's why we need to have high index of suspicion and then follow up high risk group of patients. But right now, the tumor marker that is available for pancreatic CA is actually CA19-9. And it is not just for the early pancreatic cancer. It is actually high in patients who have pancreatic cancer generally, but the degree of the amount may be higher for those that are of late stage. And it is used also to serve as a baseline for patients that you want to treat, so that you know, you can use it to monitor the response for the patient. So I would say that there's not a single test that has been outlined for pancreatic cancer per se, but there are blood tests that one has to do. And then when patients are in the high risk group, CA19-9 is a tumor marker that would be used to screen. And then the patients are followed up, and then when they have high index of suspicion, then they are subjected to regular CT scan imaging modalities like ultrasound, CT scan, or MRI. And then if there's high suspicion of cancer, then biopsy will be taken. Biopsy is the confirmation. That's what the confirmation test for any form of cancer, and it includes that of pancreas. So I wouldn't say there's one test that can be done to diagnose early pancreatic cancer. It's a series of things that you will do: blood tests, DNA analysis, and all that put together to make a diagnosis. Thank you.
Thank you. There's a question here that is, I mean, I'm very happy because the person also has said is a catch-22 question. But even I was thinking about that. Okay, the effects of chemo at late stages as for treatment, it affects the body generally. So
yes,
with somebody already going through, somebody who has, like you say, 80% present already at late stage, their system is already weakened. So how does the treatment help to, what's the chance? Because it's now that's a catch-22 when you're talking about pancreatic cancer, late stage, chemo. Okay. We already know, I mean, I'm a specialist on that one. Your body feels the effect. So how do you go from that?
All right, thank you very much. Yes, chemo is mentioned as one of the treatment modalities, but I would tell you that 80% of pancreatic cancer patients are actually not fit to have chemo, and they will not be amenable to it. That's the truth. Most of the time, by the time you are getting these patients, they are at a stage where even their performance status is really low. There is a score that we have that is called the performance, you use it to score a patient's performance score. And once the patient's performance score is less than a certain level, the patient is not fit for chemotherapy, and so you cannot give chemotherapy. So we use that to guide, the choice of chemotherapy. And then even if you have to place these patients on chemotherapy, when you see patients that are weak, and they cannot withstand this chemotherapy. There are a lot of chemotherapeutic agents, and they are also combined in different proportions. So depending on how fit the patient is, most of the time, my patients are not fit enough to even have systemic chemotherapy. So you just give them some oral chemotherapeutic drugs that have less effects, and then hope that it works. But of course, as I said, the aim is not cure. And you wouldn't want to treat a patient, give chemotherapy, and then the patient dies more of the complication of the chemotherapy rather than the disease itself. So you have to balance the performance status of the patient, the stability of the patient, how well the patient can tolerate this before you think of giving chemotherapy. But for me, with my experience, 80% of my patients who present with pancreatic cancer are not fit for chemotherapy.
Is anybody in the house who has questions for doctor? Please put up your hand and I'll put you through. I know that this topic is a very hard one. That is actually, but it's the last one for the year. We have to address. We can't keep running away from pancreatic cancer. That is honestly the reason we're having to talk about it.
Okay, there's something on the chat. Can I just read something on the chat? It says, so doctors are aware of this and should take this assessment before administering chemo. The truth is that there is no doctor that wouldn't give a score of the performance of the patient before deciding whether or not the patient is fit for the treatment. So doctors will always use that assessment score to score the patient and decide whether the patient can have chemotherapy, or you should start thinking of discussing in line with palliative care. Of course, the palliative care is not all about just supporting the patient. It's also about letting the patient know that this is an end-stage disease, and you need to start rounding up, making things up, and trying to put yourself together. It's not a very palatable thing to discuss with patients, but it gets to that stage where these are the things that you need to start discussing with the patient, not hurrying to give the patient chemotherapy, because most of the time, the complications of the chemotherapy may even kill the patient right before the disease itself.
Okay, so basically, since we already know that pancreatic cancer has its own challenges, the problem is much, okay, I want to try and be realistic. A question has come up. In light of all the complications of this, a question came up about people's sex life at that point. I'm not sure how that works, but I have that question.
Okay, people's what?
Sex life.
Okay. One of the high-risk group of patients that have pancreatic cancer are patients with diabetes or chronic diabetes that has now, not responding to treatment, or those with new onset diabetes. So there may not be a direct link with sex life to pancreatic CA. It may be related to that aspect, because remember that diabetes has a lot of effect on the body to affect even the fertility status and even sexual capabilities of patients with diabetes. So that may be where the link is, but a direct link with pancreatic CA, or maybe the complications of the treatment too. If patients have chemotherapy, it may actually reduce their fertility status, even their libido and things like that. And if patients have maybe radiotherapy to the region, remember the pancreas is around the abdominal region, it may affect it, but there's no direct link that I know of pancreatic cancer to sexual ability, but of course it had to do with, remember, it's a chronic disease, and the patients are in late stage. So all that, for you to have a good sexual function, of course, everything within you has to be balanced. Remember that sexuality is hormonal related, sort of. So a lot of things can actually be implicated. It may not be a direct link to the pancreatic cancer, but some other things that are happening around within the patient with pancreatic cancer. Am I still being heard?
Sorry, it was me. It was me. I put it on
Hello?
mute. Sorry, it's me. I was on mute. Can pancreatic cancer be contracted besides being hereditary or having other pancreatic associated diseases?
Hello, can you hear me?
No, we can't. We can hear you. I don't know if you can hear us. We can hear you.
Hello?
Hello?
Wow, all right.
Okay, there's a question on the notice board that you can see.
Hear me?
Yes, I can hear you. Yes. Yes.
Okay, can pancreatic cancer be contracted besides being hereditary of having other pancreatic associated disease?
Yes.
Well, as far as I know, no cancer can be contracted. Let me put it that way. So apart from the associated factors and then the sporadic, maybe the associated risk factors that I have mentioned, and then for most of the cancers are actually sporadic. They just occur without no associated risk factor. Pancreatic cancer cannot be contracted. In fact, any cancer cannot be contracted. It's not like HIV or, so I don't know. Contracted, I want to believe, is like by associating with someone or something. I don't know. It cannot be contracted.
Yeah, that's why I didn't know. That's why I didn't read it. I didn't know how to. Okay. There's another question there for you, Dr. Tessy. You can see the questions. Because me, I'm no longer clear of this thing again. The double function of Dr. Tess, you mentioned the double function of the pancreas in respect of enzymes and blood sugar balance.
Okay, can you please hear?
Sorry? I can hear you.
How directly does it affect hormones in normal function?
Yes.
And when affected with cancer?
Yes.
So of course, I mentioned the fact that the pancreas has double function, but again, it's interesting to note that actually the pancreatic cancer actually most of the time affects the exocrine function of the pancreas, not the hormonal function, not the endocrine function that has to do with insulin and glucagon and hormonal balance and their balance. Most of the pancreatic cancers, more than 90% of the case, affect the exocrine function of the pancreas. Have I answered that question?
Sorry, whoever has asked it, has the question been answered? I'm not. I won't be able to. Okay. Okay, most probably you have, because there's no feedback.
Okay.
Okay, and I have one question I want to ask you. Because of all the testing and all the doom and
okay, ma'am.
Can you hear me? Can you hear me, Doctor?
Yes, I can hear you.
You can hear me, okay.
I can.
With all the doom and doom that comes with it. Okay, the person has answered. He said yes, as it seems why it presents with weight loss. Okay, thank you. Thank you for confirming that. With all the things that come up with cancers on their own, and the challenges that people go through, and we bear in mind the issues of pancreatic cancer in its own already stage 4 stage, let's put it like that, stage 3, 4 stage. How do we as human, how do we protect ourselves? Because you've mentioned things like diets, exercise, but everybody else says that about cancer and all these symptoms that we go through, fatigue, nausea, the change in stool, they are all very common markers in almost all cancers. So one of the things I've always said is if you feel sick and it's just not going away, you need to address it. What would be your one sentence guide that would say, if this is wrong with you, just know that you need to be sitting in front of a doctor? That's what I'm trying to get at. Did you get that?
Yes, I did. I don't know, putting it in one statement will be difficult, but I would say
just that, go on, not one statement, just go on.
Okay, so I would say that we should pay very, very particular attention to our health. We should be very conscious of our health and have a very high index of suspicion. We shouldn't take any symptom, any new symptom for granted. Any new symptom for granted. So if you find a new symptom, we should just improve our health-seeking behavior. I think that's what I would say in a nutshell. We should improve our health-seeking behavior. Don't sit on any symptom that you are not comfortable with. And if you go and see a doctor and he sees you, prescribes whatever it is, or asks you to do a test, one test or the other, and it's not being solved, please go back again. There's no number of time that is too much to see a doctor pertaining a complaint that has not been solved. So I will say in a nutshell, we should all try to improve our health-seeking behavior. Don't you ever sit on any symptom, and continue to seek solution, even when you are told that there's nothing. I've realized that most of the patients that come with early stage cancers are patients that are very, very conscious of their health, and they have high index of suspicion when anything is wrong with them. And you can only do these things when you also educate yourself. The internet is there. Most of these things are free on the internet. You need to also be informed, like really informed. Go the extra mile to get yourself informed about diseases and your health status, so that when you have things like this, your suspicion is so, your index of suspicion is so high, and with that you can seek help in good time. I think that's in summary what I would say. And of course, this applies to any cancer or any disease for that matter.
Thank you, Dr. Tessy, because thumbs up is there. Right on. Ask the question. I don't have, my questions are running out. Let me see. This high index suspicion, yes. Well, everything that you have said from my own perspective, I would say thank you, because they are facts, and we all try to run away from this cancer conversation. And because it does have a lot of stigmatization to it, we have to be honest. You cannot run away from cancer. We have to face it. Is there anybody else that wants to ask one or two questions before we shut down for the day? You can put up your hand if you want to talk, or I will let Dr. Tessy ride on with us. Okay. Dr. Tessy, I want to seriously thank you. I know this was a very hard topic, and to be honest today, I think one of the challenges about the conversation on pancreatic cancer is because it is known, like you said, 80%, how do you say it? 80% stages 3 and 4 presentations. I'm now understanding the word presentations. It took me a long time. One of my friends is online who teaches me these things. But with this presentation statement, it has helped, I think, us to know, because of the awareness of what Dr. Tessy has explained, does not automatically mean any of us have cancer or have pancreatic cancer. But for the message about a family member that has had it, I would suggest that you go and get some what do you call it? Get some advice and medical checks on that one, because there's not much we can do. Is that correct? Dr. Tessy, am I saying the right thing?
Yes, you are.
Okay.
Yes, you are.
And then if there's any of you, Dr. Tessy is based in Abuja. For those who may want to speak to her, please contact her. I will share. I will share Dr. Tessy. Reach out and I'll give you her contact number directly. You can meet her at her clinic at the Federal. Actually, she did tell me what it's called. So hold on, let me just tell you where she's based. And Dr. Tessy, sorry, I have somebody that I will send you. I will send their contact. I will send them your contact today.
Okay. No problem.
The person is based in Abuja. They need some help. So I'm not sure. Dr. Tessy, oh, sorry, I can't. I'm looking at apps. Apps are not very good, you know. They make you confused. I'm looking at my apps and wondering.
Okay, so what information do you want?
I wanted to say where you are. You are based at the Federal Medical Center in Abuja.
Yes, I am.
That is where they have the multidisciplinary cancer center. To all those who don't understand what that means, it means that in that particular unit, all the different aspects of the cancer treatment is provided. I think I'm right on that, Dr. Tessy, but it means everything. They have their multidisciplinary meetings, which means the cancer, the chemo, the help, the mental health people. There's a lot of people that are involved when decisions are made for cancer patients. And that is what that multidisciplinary cancer committee is made up of. So that will be a very good center for you to be looking for help if you require any at this point. I'd like to thank Dr. Tessy for this session. Thank you. And yes, I know that the laptop didn't allow us to see your face, but at least we heard you loud and clear. So on behalf of Common Cancer Foundation, I'd like to say thank you. And we look forward to seeing you again. Maybe at the
I'm trying to show my video so that you see that I'm outside. I actually came outside.
Ouch.
I'm just standing outside to make the presentation actually because
network was not.
Yes, the network was bad inside, and I'm like, no, this thing I've been preparing for like 2 weeks. I must give this presentation.
So thank you very much. Thank you. We really, really appreciate. And to be honest with you, you've actually had a lot of interesting questions, which I didn't expect, to be honest, because I know the fear of the word pancreatic cancer. So, and I can actually say I do know a couple of people that have died of it. So thank you very much for this time, for your time, for sharing with us, and for all that you have done. You know, we really appreciate you. So on behalf of Common Cancer Foundation, we want to say thank you. For all of you online, you can find our videos. All the videos are on Common Cancer Foundation's YouTube channel, on our Facebook page. It has been on live, and on our, Instagram, we do put up clips. Dr. Tessy will be on most of them, so there will be directions for people to go and find the information that she has shared today on any of those spaces. You can also follow us on our website. You get information of our events on our website. We are finishing the monthly Common Cancer Let's Talk About It series for 2021 today. So I give you a round of applause to all those who have been with us and all those that have continued to encourage us. And Dr. Tessy, you were the one that rounded up 2021 for us on Let's Talk.
Wow.
So we want
thank
to say
you so much.
Thank you for that. Anybody who has questions,
so
anything you want from us, please do not hesitate to reach out. We do have quite a lot of oncologists like Dr. Tessy who work with us, and we are hopeful that you will be able to get support from them if you need any, or at least they can signpost you to the right doctors. As you know, Denise Ejo is not an oncologist or a medical doctor. I am an academic doctor. So I want to say thank you all to everyone, and we look forward to seeing you next year in 2021. We have a lot going, and hopefully we will celebrate World Cancer Day in Nigeria. I don't yet know how, but when I get in, I'll go and sort it out. So hopefully then we'll see you, Dr. Tessy. As we think about what we're going to be doing for 2021. We look forward to all of you.
Thank you so much.
Lovely holiday, and see you in 2022 by the grace of God. Have a good day.
Bye.
Dr. Tessy, I'll call you later.
Okay, thank you, ma. Bye.
Thank you. Oh, thank you all, everyone. I'm coming out now.